Welcome everyone to today's webinar, Fall Prevention in Primary Care, How to Do It. Today's webinar is facilitated by the Loop Fall Prevention Community of Practice. My name is Michelle Dukman and I'm the Knowledge Translation Coordinator for the Fall Prevention Program at Parachute. Before we begin, we'd like to start today's presentation with a land acknowledgement. Today, we respectfully acknowledge the land on which we live and work as the traditional, ancestral, and unceded territory of the Indigenous people, Canada's First Nation, Inuit and Métis people, whose presence reaches back to ancestral time. We respect and affirm the inherent rights of the title of Indigenous People of Canada and declare our respect of Indigenous elders, past, present, and future. I would ask that everyone takes a moment to themselves to acknowledge the land where they currently reside. Next, I'll go over a few housekeeping items. During the webinar, if you have questions about the technology, please put them into the chat box. My colleague Marguerite will be monitoring this. Our presenters will also have a couple questions for you to share your input. Please feel free to use the chat box when you're answering those questions. If you have questions for our presenters about the content of the webinar, please submit them through the Q&A box. They'll be answered at the end of the webinar, and you'll only be able to view the questions you have asked, not the questions posed by other participants. So we'll have a designated Q&A time at the end of the presentation. This webinar is being recorded, and a link to the recording will be sent to all participants in a few days, along with the link to the presentation slides. As many of you on the line are already Loop members, I'll go over this quickly, but for those who are not, we encourage you to sign up. Loop is the no-cost online communication platform for the Fall Prevention Community of Practice, and it uses this to bring together its members from across Canada to problem solve and discuss how to implement evidence-informed and promising fall prevention practices. And here on the slide, we've got a couple of the key features that Loop provides its members. And as a reminder, the recording link and the presentation slides will be posted on Loop in a few days. Now, I'm going to turn it over to our presenters, Trish Rawn, Academic Detailer and Clinical Service Director, and Nicole, Seymour, Academic Detailing Pharmacist. Both are from the Center for Effective Practice. You can find a complete bio for both of our presenters on Loop, but without further ado, I'm going to please say, take it away, Trish and Nicole. You can now share your screen.
Thanks, Michelle, and thanks to Nicole for sharing her screen. So good afternoon, everybody. Thank you so much for taking time out of your very busy schedules to join us today. I'm Trish, and that's my colleague, Nicole. We're very excited to speak with you today about implementing fall prevention initiatives in primary care. So first of all, a little bit about our center. The Center for Effective Practice is one of the largest independent not-for-profit knowledge translation organizations in Canada and for primary care. And we were established in 2004 through the Faculty of Family Medicine at the University of Toronto. And since then, we've branched off and are now on our own in knowledge translation. And our main goal is to bridge the gap between evidence and practice. So here's a sample of a few of our tools and resources. As you can see, we've got quite a few. There's up to about 29 of these. And this is one of the ways that we achieve our goal of branching the gap between evidence and practice. Our tools are freely available at cep.health. And some of you may already be familiar with some of these resources, such as our popular COVID Resource Center, the recently updated Medical Assistance in Dying tool, and the Core Back tool, just to mention a few. So when you do have a chance, take a moment to glance at some of the great clinical tools that are available on our website. So in addition to clinical resources and tools, CEP also offers a primary care academic detailing service in Ontario for family physicians and recently also for primary nurse practitioners. Academic detailing involves a personalized, evidence-based best practice discussion. CEP's academic detailing service is delivered by clinical pharmacists, including myself and Nicole. And for each topic, we do a deep dive into the literature, guidelines, resources, and practical tips from healthcare workers and patients so we can best address the current recommendations barriers and solutions for the topic. One of these topics is falls prevention. And now we've had more than 200 academic detailing discussions with family physicians and nurse practitioners in Ontario. Here's an example of some of the most common questions providers have for us during academic detailing discussions. These discussions have provided us with some real world perspectives and appreciation for the value of involving all team members in falls prevention, and also an appreciation for the hard work that everybody here is doing on a really challenging topic. And just to get an understanding of the diverse primary care audience we have with us today, can we ask everyone to type their name, profession, roles in falls prevention, and practice location into the chat box? And while you're typing, we'll do a little bit of disclosures. So myself, I am an employee of the Center for Effective Practice. I'm also an employee of the Mount Sinai Hospital as a casual inpatient pharmacist. And we receive our funding at the Center for Effective Practice from the Ministry of Health and Long-Term Care. That's funding both for the detailing as well as the knowledge translation. And I will turn it over to Nicole to do a bit of an intro on herself.
Thanks, Trish. Seeing lots of interesting results in the chat here as well. Lots of OTs and PTs, wide range of kind of roles here. I myself am a pharmacist, and I work for the Center for Effective Practice as well as the St. Thomas Elgin General Hospital. I will do some casual part-time work for RX Files and NARCAD as well, but I don't have any commercial conflicts of interest.
Excellent. Also, I have no commercial conflicts of interest to disclose. So thanks, everybody. I'm seeing amazing response here in the chat window. As Nicole was saying, OT, PT, clinical coordinators, managers of the falls prevention programs, physiotherapists, balance classes. This is fantastic. We're going to get a lot of great perspectives here, and also great representation from around the country. So thanks everyone for sharing this. And see some nurses here as well, social work students, nurse practitioners, and physios. So fantastic, a really good representation from everybody. As we go along, if you do have any questions, you can enter them and into the Q&A, and we'll do our best to address them at the end. And until then, so we're also going to be posting some links to resources within the chat. We'll also be circulating those after the presentation. As with the other Loop webinars, this will be recorded. We'll be encouraging participation throughout with boxes and questions for you to answer in the chat as we go along. And please do enter your questions in the Q&A. Let's get started. Okay, so what we're hoping to get out of today is to identify a few simple questions that can help reduce the risk of future falls, to review risk factors and interventions for falls, and also identify some useful resources. So to wrap everything up, Nicole will walk us through ways to incorporate the information from today's session to streamline improvements in patient care. Okay, so putting it out to the group here, please enter in the chat what your biggest challenge is in terms of preventing falls. Now, if this were an academic detailing visit, we'd often open the conversation with this type of question to help us learn more about the obstacles that you face in your own practice. Even during this presentation, we're really interested in learning about your challenges when trying to implement falls prevention interventions. So please feel free to share, and we hope that throughout the presentation, we can offer some practical tips and support tools to overcome some of these challenges and make a difference in your practice. I'm seeing quite a few interesting things here in the chat. Reducing ED visits and hospitalization, consistency of practice, declining cognition, follow-up and interprofessional communication, judgment, patient judgment, or documentation, family participation, and then just the physical challenges of mobility. Coordination of care is appearing a lot as a theme. Preventive screening and the lack of screening, encouraging participation and following recommendations, the consistency of staffing. So a lot of factors here. There's team factors, communication, staffing, there's patient factors in terms of physical challenges and intellectual challenges, as well as, getting on board to follow the recommendations. And then just access to resources and sort of understanding what programs are available for patients limitations of virtual platforms. So seeing a lot of follow-up and interprofessional communication going on there. So hopefully we can help a little bit with this. The myth that restraint in wheelchair is the best way to prevent falls. Again, that's another important one, complex care and transportation. So I don't know if we can solve everything, but certainly environmental factors, communication, all these things, finding quick ways to do things in your practice, we'd be happy to hopefully address and also encourage some dialogue amongst participants. Okay. So while you're sharing your experience, I also wanted to share some of ours. And one of the things we learned from detailing on falls is that, as we're seeing with the chat, many of us have been touched by falls. In our visits, one of the first things we do is ask the clinician about their most recent or vivid experiences with falls. And these are two of their stories. The stories are real, but the names and some of the details have been changed to protect the patient identities, and the photos are not the actual patients. So it's just an example of how differently things can go when you have systems in place to prevent falls. Robert, age 82, lives alone. His wife passed away a couple of years ago and has no children nearby, and not much of a social support system. When he didn't show up for a doctor's appointment, his family physician went by his house to check on him and found he had fallen on the floor of his bathroom 2 days ago and broken his hip. He didn't have a phone or a lifeline with him. He couldn't get up, and no one heard his cries for help. He was able to get water by drinking from the toilet bowl, but he was weak with hunger and pain by the time he was found. In contrast to Marion, who was age 78, had a system with her neighbor, Sue, where every morning Marion would raise her blinds if everything was okay. If the blinds didn't go up, Sue was supposed to knock on Marion's door. And if Marion didn't answer, Sue was supposed to use a key that Marion had hidden under her mat to let herself in to check on Marion. So one day Marion's blinds didn't go up and she didn't answer the door. Sue found the key and let herself in, only to find Marion on the floor outside her bedroom where she had fallen recently. Marion was shaken, but her system had worked. After that, she started carrying her cell phone in a fanny pack so that she could call for help without having to wait. So these stories illustrate the difference that just one simple intervention, having someone check on you every day, can make. We focused on identifying simple yet practical interventions like this one for the clinicians in our detailing sessions. So the majority of information we're sharing today can be found within CEP's fall prevention tool, which is available for free download on our website. Victoria is going to share a link in the chat box to this tool. So there it is. Okay, so why are we looking into this, and why is this such an important issue? If we look at the evidence, falls are the leading cause of injury-related morbidity and mortality amongst people aged 65 and older and living in the community. Those who've experienced recurrent falls, which is more than one per year, are at an increased risk for morbidity and mortality. The good news is that most falls can be prevented. As a crucial component of geriatric care, healthcare providers can work in partnership with older adults to implement a variety of interventions to help reduce the risk for falling. And we're going to take a closer look at the different types of interventions throughout this presentation. So first of all, we're falling short when it comes to falls reporting. Less than half of patients tell their doctor they've fallen, and only 10% of physicians discuss fall preventions with older adults. So what's happening here? Why are patients not readily telling their provider about falls, and why aren't they being asked? On the patient side, this can be due to fear of stigma or losing independence, or just feeling that this is a normal part of aging that they should be able to handle on their own, not wanting to make a fuss. On the clinician side, it can feel like opening a huge can of worms they may not have time to address during the patient's visit. So let's make this as easy as we can. When it comes to knowledge and perception on the patient's end, older adults tend to under-recognize their fall risk and under-report falls. They don't know that falls are preventable and not a normal part of aging. And this can develop a vicious circle where 20 to 30% have a fear of falling that limits their activity and further deconditions them for risk of further falls. That's why it's so important to ask patients 65 and over about falls every year. So we'll talk a bit more about that screening process. So one of the first things we discussed in our visits with healthcare providers was this place to start, recommending that every person 65 years of age and older be asked about fall risk annually after hospitalization and after any significant changes in health status. So ideally, we'd love to screen everybody and also screen for after any changes in environment or health status. So you may be screening younger people as well if they've recently been hospitalized for a fall, or if they have, looking at your clinical judgment, if they've got a malabsorption condition, an eating disorder, or anything else that might increase their risk of either fractures or falls. So instead of screening everyone 65 plus, if this does seem a bit overwhelming, which it often does if you have a geriatric practice, look to screen a subset of patients such as 75 plus, or screen opportunistically, for example, after hospitalization, after a bone mineral density, or after a relevant medication change, such as a psychotropic medication. So now we've discussed who to screen, it's also important to know how to screen. So one simple question can give you plenty of information to start making interventions to help patients. And that question is, have you fallen in the last year? Among many studies, history of falls was the most commonly used factor that consistently identified persons at high risk for falls. This question is also important since, as we mentioned earlier, less than half of older patients that fall tell their doctor. So hopefully if we ask, they'll tell. Once you've asked that question, you'll get one of two responses. Yes, I've fallen in the past year, or no, I haven't. Hopefully you won't get the third option of I don't remember. We're first going to take a closer look at next steps if the answer is no. If the patient hasn't fallen, it's still important to also ask about balance, gait, and mobility. Balance, gait, and mobility can be assessed informally by observing how a patient walks into the exam room or asking the patient if they feel unsteady on their feet or have a fear of falling. It can also be assessed formally by performing the tug test. There's going to be a video in the chat about that, and we can share that after. If no concerns are found with balance, then it's also important to assess physical activity and nutrition, which we'll further discuss in a few minutes. On the other hand, if the patient answers yes, they have fallen, or yes, they're having issues with balance, gait, or mobility, then we can screen the patient for risk factors and apply multifactorial interventions, which, according to most guidelines, is where the bulk of the evidence lies to show reductions in falls. So let's delve in to how to assess and intervene for each of these risk factors. So first of all, knowledge and perception. People's perception of falls can vary greatly based on their thoughts about why they fell. There are certain beliefs about maybe they could just be more careful and it won't happen next time, or they have a logical reason for why the fall happened so that it wouldn't happen again. What explanations or themes do you often hear from patients? Do they recognize external factors for improvement or their own limitations? And while you're typing in the chat, I know Nicole has a personal example here.
Yeah, that's right, Trish. Many older adults also downplay their struggles. Maybe they don't recognize them, they don't want to complain, or as you mentioned, they're afraid of losing independence. This is something I've seen firsthand with my grandma. At 93, she's doing just fine. She can't complain and she's managing all right. In reality, we know she's fallen several times. If you ask her, it was her fault for one reason or another. Last year, she had an in-home assessment and the occupational therapist asked Grandma to climb the stairs. We had already installed a handrail on either side of the staircase, so it must be all right, right? The occupational therapist and I watched in horror as Grandma used the handrails on either side of the staircase to climb her way up because her legs were too weak. She told the occupational therapist that she thought this worked just fine and she was managing, no complaints. She even had an answer to how in the world she managed to do that with her laundry that was in the basement. She's a farmer. She made it work. That's what you do. It sort of makes sense though. No one likes the idea of getting older, becoming frail, or worst of all, needing modifications or help. There are many generational factors in there. This is where family, home assessments, and asking the right questions can be especially helpful.
Thanks, Nicole. And I'm seeing some great quotes in the chat here. Anyone would have fallen. I didn't hurt myself, so this wasn't really a fall. Well, I didn't fall, I just slipped off the bed, or I just lost balance. So not wanting to necessarily say it was a fall. It was just one time, it'll never happen again. A lot of people don't know a slip or a trip can be considered a fall because they didn't land on the floor. It was dark, I tripped over my dog, my cat. I was rushing, I tripped. So explanations for why it happens that are environmental. I was carrying something, or I'll be more careful next time. The theme of I didn't hurt myself, so it wasn't a real fall. I turned too quickly, seeing a lot of commonalities there of just not wanting to acknowledge that this is something that happens despite other things in the environment. So thanks everybody for typing in your experience with this question. So how do patients feel? And how do we talk to them when they're not so keen on the subject matter? Throughout our FALS tool, we have what we like to refer to as talking points, which are basically conversation starters based on patient-centered interviewing techniques. So the ask, tell, ask, like motivational interviewing, that help us get a better picture of a patient's beliefs and ideas about falls. So saying a few things to normalize the experience. I ask all my patients 65 and over about falls. Explaining what a fall is. Trips and slips do count. Explaining that many falls are preventable. And, would it be okay if we talk about some ways to work on this? And so we actually have a even further detailed list of phrases in the tool, but that's just sort of a rough sampler of what that's there. If they're capable of refusing intervention, other than offering education, they do have a right to refuse support. And that's a great point. There is a balance between autonomy and reducing people's risk. And all you can do at that point is recognize that you may not get anywhere the first time you speak about it. And that perhaps it might be a matter of just sharing some information, letting it sit for a while, involving a family member, or potentially talking about goals. Like, in a few years, where do you see yourself? What would you like to be doing? And then try to bring that alongside where that patient is looking to be, and capitalizing on the independence factor, that if their independence is so important to them, what if there was one or two things you could do, simple things around the house, removing some floor mats, kind of these gateway simple things where you're still independent and you're not really getting help, but you're just making a few changes around the home. Sometimes that can be a gateway into getting a bit of help. So I wanted to get people's input on this one. Who is using the staying independent checklist? Is this one that is a big part of? Yes, I've seen some folks are, yep, lots of yeses. So this is an important one for us as well in our visits. Quick tips for falls prevention and patient-friendly language. Looks like we're seeing a lot of people familiar. Some folks probably have other checklists. There's plenty of great ones to choose from. The Center for Disease Control has a nice one as well for home safety. The important thing not necessarily is which checklist to use, but just to have a checklist that's patient. We can talk a bit more about that too.
And Trish,
So,
I like this checklist as well, sorry to jump in, but it does give a broad range of things. If people aren't really keen on making modifications to their home, well, maybe there are other things that they are willing to work on that might be more acceptable and might actually help them achieve things that is a win-win for them.
I love that idea of giving people a menu and just saying, is there anything you see on here that you might be willing to do? And there may be things that no one's ever mentioned to them before. So I love that idea. All right, so next, now that we've screened and identified patients at risk, what do we do next? Again, if a patient answers yes, they've had a fall in the past year, or no, but they do have gait mobility issues, then for these patients, it's recommended to conduct a comprehensive assessment to identify factors contributing to the patient's fall risk and to implement a tailored risk reduction strategy that targets the patient's individual risk factors. So here you can see some of the main fall risk factors listed. What we're going to do next is take a closer look at each risk factor and quickly review how to assess each risk factor. And if the risk factor applies to a patient, we'll look at how to manage the risk factor and also share both patient and provider resources with you. Needless to say, if delving into a comprehensive assessment to identify which factors may be contributing to a patient's fall risk, this type of assessment would take place over several visits. Now, if you're thinking to yourself, wow, this seems like a lot of work, and even if I break the assessment down over several visits, it still doesn't seem doable in my practice, I'm going to ask you to hang in there with us for just a bit longer, because in a few minutes, we're going to give some practical tips on how to make this more doable, regardless of your practice setting. And don't worry, you're not expected to do this all on your own. So CEP is a Check Your Falls Risk patient form that collects the key questions from each of the risk factor categories so you can quickly identify the most important one to address. This is a little different from the Staying Independent checklist, since it is meant to comprehensively collect information about history and risk of falls for the provider, rather than to provide any guidance or education for the patient. So we're going to dive into each of these now. First of all, falls history. So if a patient has fallen, it's important to gather information about the circumstances regarding the fall, which can be done by assessing fall history. If your site already has an existing tool to access fall history, that's wonderful. Feel free to continue to use it. If not, CEP has put together a falls checklist that we'll be sharing with you later in this presentation that you may find helpful when collecting information about fall history. The next risk factor to consider is physical activity. For those patients who do not need to increase their physical activity, there are a few guidelines here, but the first step of this is to ask the patient about their current level of activity. And anecdotally, one of the things we found easiest is to say something like, how often do you get out of the house? And that gets at a few things. Not only are they even leaving their home at all? Because this did become an issue during COVID where people were so afraid to go anywhere, including the garbage chute or the mailbox or the grocery store, that they became quite homebound and deconditioned. And then subsequently got in the vicious circle of being more afraid to go out. So just getting a sense of what is their level of physical activity and also isolation, you can learn a lot from that question, and then sort of go from there. Asking a patient, you know, do you get aerobic exercise? Do you get muscle strengthening? If you ask directly, that can be a bit intimidating. So I like to start with a question of, hey, how often do you get out of the house? You know, do you do anything active like stretching or walking around? And then you can get a sense for whether they are actually, you know, managing to get different forms of physical activity. And if they're getting no activity whatsoever, really starting slow is the way to go. And there's a lot of benefits just in terms of simple things you can do around the house. So there are some really great patient handouts available. One that we found is pretty successful is these Too Fit to Fall or Fracture, which is from Osteoporosis Canada. We've included it in our Falls Toolkit, and it's a 2-page patient brochure that gives examples of home exercises you can do. So things that involve a chair or a wall. If you've got resistance bands, that can work. If you've got patients you feel this would be appropriate for, this is gives some easy to do home exercises. For patients where, for example, maybe they're in a chair, setting small practical goals such as doing sitting exercises during commercial breaks can be beneficial. Every patient's different, and it's important to meet the patient where they're at and to set realistic goals when it comes to physical activity. Even a small amount can make a big difference. What are some of your favorite resources for physical activity for seniors? Feel free to type in the chat. We've noticed that some local TV broadcasting stations or subscription services have exercises for seniors right on TV. If they're already in their chair watching TV, it's an easy thing just to flip the channel. There are also many online resources with videos, handouts, and information about physical activity. This is one that we have seen, YouTube at More Life Health. They have very simple workouts that also are varied in terms of their duration. So short ones, long ones, and you don't need any special equipment to do them. I see a comment here, tiered exercise program for the Canadian Centre for Activity and Aging. That's fantastic. The Canadian Centre for Active Living, home activity program through BC, and also Cassandra's point about community programs. Community fitness also boosts the social connections as well. So you're sort of getting at 2 risk factors at once. Better yet, you can also use a multimodal approach, sort of leads us nicely into our next slide, community health centers, senior centers. You're getting a little bit of activity, but you're also getting some social support as well, learning about balance and staying on your feet. There's a wide range of offerings here. Often they're called things like staying independent, balance support, staying on your feet, falls prevention. So looking in your local community can be helpful for that. So nutrition and hydration. This is a really important risk factor because malnutrition affects 1 in 4 older adults. And one way that is easy to assess this is just to say, what do you eat in a typical day? This helps get at the idea of, you know, are they cooking for themselves? Are they eating tea and toast? Do they have food insecurity? Are they able to afford healthy food, to get access to food? And so this question will help uncover not only do they have adequate food intake, but also, you know, are they in need of any social support? If you do identify in older adults, on the next slide, with risk of malnutrition, you do have some options available. So keeping in mind, there are some dietitians free of charge, things like the local grocery stores, falls and frailty clinics, some clinics and health centers can give advice and support there. Some provinces and territories have patient coordinators to assist with the social and medical needs, including dietary consults. Healthy Eating for Seniors provides basic nutritional information. That's Health Canada's Food Guide website there. Also, often patients with chronic conditions have free access to a dietitian via their specialist, whether it be through their nephrologist, cardiologist, etc. So the good news is that some patients do have no-cost options when it comes to accessing a dietitian. When it comes to food insecurity, food banks, social assistance programs, and provincial and local repositories are a great resource. So I'm now going to hand it off to Nicole to discuss the remaining risk factors. All yours, Nicole.
Thanks, Trish, and thanks everyone for sharing all the fantastic resources out there. Let's look at medications that can be implicated in falls. This isn't an exhaustive list, but some of the worst offenders are here. Which medications do you usually worry about with respect to falls? Do any kind of jump out at you when people tell you what they're taking or you see a medication list? When I talk to doctors or nurse practitioners, I often get asked, which medication should I start with for the biggest impact? The answer always comes down to the individual patient in front of you and their specific symptoms, risk factors, preferences, and the indications for the regimen they're on. I'm seeing a few options in the chat: benzodiazepines, psychotropics, and OTC meds. Thanks, Erin, for mentioning that. Always ask about over-the-counter medications and herbal products as well. So important. And yeah, gabapentinoids for sure. It's important to confirm what the patient is actually taking and how they're taking their medications. A medication review can be completed through a community pharmacist, a clinic-based pharmacist, or just in the office or in your setting as appropriate by doing a brown bag medication review. When you have the person just bring in all of their medications and you look through them. Keep an eye out for the date of the last refill and the amount left in the bottle, just so you can get a sense for how regularly they're actually taking that medication. If you identify issues, you can always consider blister packing or having a home medication review done. Home medication reviews and home visits can often be enlightening in many ways, including seeing how much old medication can be disposed of. A geriatrics referral can also be used, as they'll often take the time to do a really thorough medication review as they have the resources. Anytime we assess medications and fall risk, we should be asking these 3 questions. First, might it increase or did it likely increase the risk of that fall? 2, can it be stopped? And if so, how? Does the patient really even need or still take that medication? And 3, is there a safer alternative, such as a lower dose or a different medication that can do the same thing? There are lots of tools and resources for deprescribing that Victoria will include in the chat box, including MedStopper, which I like because it highlights tapering approaches and withdrawal symptoms to monitor for, with a wide range of medications that might not have easily accessible information elsewhere. Deprescribing.org has a great repository of decision aid algorithms and patient handouts that can be extremely insightful. And the evidence-based Empower patient information packages from the Canadian Deprescribing Network have been specifically designed to motivate patients to consider tapering things like benzodiazepines, opioids, antipsychotics, some OTC meds, and many other higher risk drugs that are implicated in falls. One of the key features in deprescribing is highlighting the benefits of stopping a medication outside of the world of falls prevention. Reducing risk of falls may not be the primary reason someone might want to stop a drug, but if it means fewer side effects, less cost, or just having fewer pills to take, and it also happens to reduce the risk of falls, that's a win-win. CEP also has some tools and resources available more from the healthcare provider side rather than the patient side. And for instance, we have one for benzodiazepines and one for antipsychotic use in dementia. As a pharmacist, I could go on all day about medications, but I'll pull myself away and move on to the next item for falls prevention. Home safety. This one's huge. Home safety assessments may vary depending on the pathways available in your region and patient preference. Obviously, an in-home assessment by a trained clinician is the gold standard here, so it's good to know how to access these assessments locally. If you'd like to learn to do home safety assessments yourself, AgeSafe Canada is an option for training and certification. Another important question is, do they have a plan for what would happen if they fell and couldn't get up? The physical skills are taught during falls prevention classes. Falls alarms through monitored services are also fantastic, but they're not affordable for all. Some smartwatches or smart home systems have falls alerts. Keeping a phone in a fanny pack is an option, and asking how often they have people visit, call, or check in on them can be important to know. Remember Marion and her trick with the blinds? It can be really as simple as that. A home safety checklist can also be provided as a simple first step for patients to learn about home safety. There are a few options available in various formats, including the Health Canada Safe Living Guide. The Arthritis Society also has a whole site with a landing page on the assistive devices resources that provides links to different options to improve accessibility in each room of the house. Which home safety resource are you most familiar with? The CDC study program has a 2-page educational brochure that can be helpful for patients or their family members to get started on some easy improvements. A particular focus is on the pathway from the bedroom to the bathroom, as getting up in the night to use the bathroom is a higher risk time for falls. At this time, a patient may be groggy from just waking up. Maybe they had a sedating medication at bedtime. They may or may not be using their assistive device. Maybe they have an orthostatic drop and their blood pressure is low. They're rushing to the bathroom. They probably can't see very well, and they're likely not putting any assistive footwear on that they would probably wear or hopefully wear during the day. This is a recipe for risk. Seeing a few other things in the chat. So the staying independent checklist, yep, it does have some home safety modifications. It's perfect. And yeah, Lifeline is fantastic for those that can afford it. Great. The stay on your feet checklist, yes, wonderful. So we often hear, unfortunately, that people aren't so keen on making big changes. Some people really don't want anyone coming into their house. They're having enough interventions on their own. They think they're managing just fine. How do you motivate them? Well, this isn't a comprehensive list, but just so you know, the actual interventions to improve home safety can be as small as removing mats, as I'm sure you're aware of, adding night lights, taking off reading glasses when using the stairs, or reorganizing things so they're easier to reach. That is to say, there are some smaller changes that may not seem like a big deal, and they might be appreciated and acceptable to people who aren't ready to make those bigger changes. Options that may be a little bit harder might include things like adding grab bars, using timers, putting in motion sensors or remotes, adding a commode at bedside or modifying the toilet, or adding a chair in the shower or in the front entryway for putting shoes on. The more costly and higher effort options might look like a stair lift or a stairway modification device, such as the Assist Step, converting the home to a single floor accessibility, modifying the bathtub, and for some people, the biggest thing you can ask them to do is to avoid unsafe activities and ask for help, including involving family, PSWs, social work, and nurses. Moving on to footwear, a quick peek at what shoes the person's wearing to see you can be illuminating. If they're wearing flip-flops, slippers, or something equally concerning for a person who is at risk of falls, perhaps recommending proper footwear is going to be your most impactful intervention for them. There are lots of options for handouts, and Victoria will share one from staying on your feet in the chat. For people who have edema, ulcers, bunions, or other conditions that make finding proper footwear harder, try to get to know your local stores that offer wide width shoes, as lack of footwear can lead to isolation. Rate My Treads looks at different footwear options and tests for how slip resistant they are using a standardized approach through the UHN Kite Lab. This can be particularly useful in the winter, or second winter as we call it in Canada, late April. Things like neuropathy, vascular disease, and other foot conditions that can impair gait, sensation, and balance should be assessed and regularly monitored. Screening and management of osteoporosis should also be done as appropriate. All adults over 65 should take vitamin D of 800 to 2,000 units per day, and they should consume 500 to 1,200 milligrams of elemental calcium, preferably in the diet. There are a lot of comorbidities that can lead to falls. Anything that impacts the brain, circulation, nerves, pain, or mobility, or things that can lead to frailty or can cause someone to rush to the bathroom would also be on the list. Managing these comorbidities, as is already being done, may actually be contributing to a reduced risk of falls. This is where I like to remind people, you're already doing things for falls risk reduction just by managing chronic disease. Optimizing those treatments is going to help for both the condition and the falls risk. Parkinson's disease and dementia warrant special mention for their especially strong association with risk of falls. Cognitive impairment may not only increase the risk of falls, it also makes it harder to get a clear picture of the situation. Further, interventions may be harder to consistently implement. Even without documented cognitive impairment, many patients will have microvascular impact on cognition and/or gait and stability. Ensuring screening for cognitive impairment is complete in older adults will help with making sure you can get the steps done to ensure ongoing safety. When it comes to social supports, there are many things to consider that might make someone more vulnerable to isolation, depression, malnutrition, accessing resources and supports, and elder abuse. Depending on the situation, connecting patients with appropriate resources can be a major impact. Get to know your local and provincial resources as a tool to share with patients when needed. The Government of Canada website has a fairly comprehensive repository of educational information and some supports related to finances, home safety, falls, fraud prevention, and caregiver resources. 211 is a fantastic national repository of resources that can be accessed online or by dialing 211 on the phone. The website or the person on the phone will help navigate the options related to social, mental health, financial, or other needs in that particular region. Which mobility assessment tool or question do you think would be most useful in your setting? Are you using any already? I see a lot of OTs and PTs here, so I'm sure you are. Mobility can be assessed in a number of ways, including the timed up and go test that Trish mentioned earlier, or just by watching a patient when they walk in the clinic or your setting. Take note of any assistive devices they use and ask how often they use them and if the device was actually properly measured and fitted to them. A good question to ask for mobility is, do you lean on furniture or cabinets to help get you around the house? If they do, it can indicate that they either need an assistive device or that they aren't using the one that they already have, and that can be explored a little bit more. The intervention may also include referral to someone that can assist further, or just double checking that mobility device fitting and getting that addressed. I see some answers here. The tug test, gait speed, chair stand, yep. Falls history and the Berg. Very good. Yeah, lots of different options there. Orthostatic hypotension is another major risk factor for falls. A drop of 20 systolic or 10 diastolic within 1 to 5 minutes of standing is considered abnormal. Ask patients if they ever get dizzy if they stand up too quickly. If they laugh and they tell you they never stand up quickly, explore why. Orthostatic drops can occur due to medications, medical conditions, or dehydration. Optimizing medical conditions, reassessing those blood pressure targets, and adjusting medications can all help reduce risk. Work with a pharmacist to help identify which medications might be contributing or interacting with each other to increase that risk. The CDC Steady program also has a great patient handout with some practical tips for reducing symptoms of orthostatic hypotension. Visual impairment is one of the more obvious but overlooked risk factors for falls. Vision loss can be so gradual that it goes undetected or it's shrugged off as part of getting older. In fact, if the vision loss is due to cataracts, studies have shown that cataract surgery on the first eye not only reduces the risk of falls, it significantly improves quality of life, which is what matters at the end of the day. For people that are out of the house often, switching from bifocals or trifocals to multiple pairs of glasses where they can take in the full field of view, especially if there are stairs or uneven terrain, that's been shown to reduce the risk of falls as well. Medications can also impact vision, so improvements may be possible with the right adjustments. So ask your patient about vision changes, encourage them to get an eye exam, reach out to a pharmacist to see if medications may be the culprit, talk about glasses, consider supports and adaptations if needed, and they may be asking about a referral for cataract surgery at the end of the day. Another area to address is oral health in falls. This isn't on CEP's tool or checklist yet, but we may review this in the future. Research has found that people who have poor oral function or difficulties with swallowing are more likely to experience falls. In female seniors, having fewer teeth and not using dentures is an independent predictor of falls. There are lots of potential explanations for this, including that medications linked to falls can also cause dry mouth. Poor chewing ability is linked to poor fitness overall. Lower oral intake can lead to weight loss and deconditioning, and dental occlusion issues may lead to balance issues. While more research is needed to establish correlation versus causation, an important step is to ask about oral health and support the patient in accessing interventions they need. Whew. All right, we got through the list. That was a lot of information. So let's do a quick recap, then my favorite section, putting it into practice.
Okay, so we've covered a lot of information. Way to go, everybody. Just to summarize our starting approach, ideally, we want to screen all patients 65 plus once a year by asking the question, have you fallen in the past year? In addition to this, a good time to screen for falls is also after hospitalization, bone mineral density, or when adjusting blood pressure medication. Remember that referring to available resources is always a great option for falls prevention and management, whether it be for home safety assessment, mobility, nutrition, etc. Also, take advantage of some of the great patient handouts that are available, such as the Staying Independent Checklist, Too Fit to Fall or Fracture, or CDC Home Safety Checklist. Keep in mind that this doesn't need to all be done in one patient encounter. It can be spread out over several visits. To make visits more efficient, involve a family member. This can be key in providing accurate information. Patients are not always the best historians, and insights as well as in helping implement interventions. And remember, information can be collected ahead of time too, to save time during that appointment. As mentioned earlier, CEP has a Check Your Falls Risk patient form that collects the key questions from the information we reviewed today, all in one place. This can be given to patients at the end of a visit to bring back next time, mailed to patients, filled out in the waiting room, or emailed. And at the end of the day, triage is always done in healthcare. What brought the patient in today? What matters to them? Try to express assessments out and use opportunistic assessments if needed to fill in parts of exams and interventions into other visits where they make sense. This could mean looking at feet during a diabetes visit, reviewing osteoporosis treatment after a bone mineral density, as you would always do, or checking orthostatic vitals when reviewing blood pressure medication renewals. Also, have all the handouts for resources and patient information readily available. People need things in writing these days. And don't forget to use the whole team. Let pharmacists do the medication review. You can always fax a pharmacy to look into whether anything can be changed to address a particular problem. Nurses, physician's assistants, and many others are able to check blood pressure or simply observe if a patient appears unsteady when walking in the clinic. Geriatric teams are also a fantastic asset. To prepare for success, you can learn about local resources for things, especially OT-PT home assessments, falls or independence exercise and learning type classes, or social supports. Take some time to obtain and display educational materials, such as posters from Finding Balance Alberta or any of the handouts or brochures we discussed. Or if you're really keen, you can complete training for in-falls and home falls assessments through Age Safe Canada or other organizations. Back to Nicole to share some EMR tips.
The opportunities are plenty for what can be done to streamline quality improvement with your EMR. You could start with doing a search for all of your patients who are in an age bracket like 65 plus or 85 plus for those of you that have EMRs. Or maybe you want to identify patients that are taking 4 or more medications or a particular type of medication like a benzodiazepine and prioritize those people for getting a medication review, however that might be done. Updating forms to capture all the information that you're looking for and having those resources handy can make your life quite a bit easier. Handouts can be uploaded, downloaded, or just kept handy as paper copies in the clinic. CEP and the eHealth Center for Excellence also created an EMR toolbar for anyone that uses TELUS PS. This toolbar was based off of the CEP tool that we just went through and captures all of the same information. My favorite part is the printable patient care plan that is automatically generated with the TELUS PS EMR tool. There are clickable boxes on the right as well to include additional patient handouts like the ones that we saw today when you're printing. At the end of the day, I like to think of all of these ideas as items in a toolkit. Everyone has their own goals and challenges and practice setting. The information we shared can hopefully provide some useful targeted tools, ideas, and resources to resolve those needs. There are many more resources, as we saw from everyone in the chat, and I'd love to hear your favorites if we've missed any that you used. Also in the chat, let us know which tips or tools you're most likely to try from the things that you've heard today. What makes adding these or other options difficult? We'll come back to these shortly and try to work through some of these answers that we see. This is part of what we do during an academic detailing appointment. Figure out what might best fit for a provider and work through the challenges they have in implementing the change they want to make. We've had more than 3,500 discussions across 10 clinical topics with 1,200 practitioners since 2018. We currently have 5 clinical topics, including falls prevention. This is a free service for family physicians and primary care nurse practitioners in Ontario as part of funding through the Ontario Ministry of Health. More information can be found on the website. Finally, don't forget that all of CEP's tools and resources are available for free online at cep.health. Scroll to the bottom of the webpage and enter your email to join our mailing list. On behalf of Trish and myself, thank you so much for attending today. We look forward to answering your questions and comments about implementation now.
Excellent. Thank you, Trish and Nicole. I want to say a huge thanks for that fantastic presentation, and thank you, Victoria, as well. We couldn't have done it without all of your link dropping in the chat, so thank you. But yeah, I just want to invite everyone I know there's been lots shared today. If you have questions for Trish and Nicole, please put them in the Q&A box. While we let you have some time to type those in, I'm just going to remind everyone that there is an evaluation survey that it'll pop up once the webinar ends, and you'll be redirected to Zoom and invited to participate in that short evaluation survey. So please do so. It'll help us to continue to put on quality webinars for all of you. And I just wanted a reminder that the webinar today is recorded, and the recording, a link to the slides, and also a document with all of the links that the team shared today will be included in that. So you'll get all of that together. I see that there are some questions coming in. One of them was already answered, so I'll dismiss that one. This first question here is from Jeanette Foreman. How did you get fall prevention as an academic detailing topic in Ontario? Did physicians ask for it? That's a great question. I know, Jeanette, you're from BC, so potentially maybe you could make it happen there.
I can answer that question. It's a combination of things. So in Ontario, we're funded by the Ministry of Health and Long-Term Care. And as part of this, there's generally the understanding of focusing on areas of high need where either there's new information or a significant practice gap, or areas where people need a lot of support. And this was identified as one of those areas where there was need for support and resources. And so part of that is sort of the sentiment amongst primary care providers that this is a topic they could use support on, and also just an understanding amongst the Ministry of Health and ourselves to say, yes, this looks like a priority area we want to focus on. So hard to comment on how to make it happen in BC, because I know their funding is a little different in their process, but certainly indicating an interest wouldn't hurt. Any thoughts, other thoughts, Nicole?
No, I know the BC PAD is the academic detailing program out there, and I'm not sure what their current list of topics is, but they are always cycling with new topics all the time. So I can maybe share their website in a moment. And I'm not sure if Falls is on the option list there, but you can always reach out to their team to suggest it if you're looking for some more education on that perspective.
Fantastic, thank you. All right, so the next question is from Sarah. She asks, is there a plan to create fall prevention toolbars for other EMRs?
At this time, I think that the Falls toolbar is kind of where it is for now until we have more funding to be able to expand. It is quite a bit of time and resources and money to create them. So right now, I'm not aware of any further development, unfortunately, but perhaps some other team might be able to take that on, or maybe some funding will come up if we're able to demonstrate the need and that there's some value to it. That would be fantastic.
Thanks, Trish and Nicole. So that's all of the Q&As that we had come up. If anyone has any last minute, hit enter now and we can answer them. I don't know, Trish and Nicole, if you have any kind of final thoughts. I'll give you a moment, since we've got a couple of minutes before we've got to end our recording.
Well, first of all, just wanted to say thank you for the opportunity to present to this wonderful group, and thank you to the audience members for being so interactive and participating and hearing us with all of our questions. And I hope that it has been useful to you, and just look forward to sort of future dialogue, and look forward to be able to support you through our website. If anyone is interested in academic detailing from the Ontario side, nurse practitioners, physicians, we welcome you to sign up and try a visit. But just very happy to be here and have the chance to share what we've learned about fall prevention with you.
Fantastic. All righty. Well, with our final 2 minutes, I'll just say another thank you, Trish, Nicole, and Victoria. It was fantastic having you. We'll be sharing the recording and the slides and all the links with everyone via email. It was great to see, like Trish said, so much participation in the chat. We'd love to continue this this interaction in our future webinars. So join Loop so you can hear more about what upcoming events we have. And thank you again. We'd love to have you back again for another presentation in the future, Trish and Nicole. Great. Thank you, everyone, and enjoy the rest of your day.